you, Shweta, and thank you, Clarinet, for providing this platform for the Reach Academics. And for this, today, last year also, we conducted one of the similar session on the OSCE. Today, also, we are going ahead as these OSCE stations are very helpful in the preparation of DNB practicals. So, I request, I need not to introduce Baldev Prajapati, sir, because he is the constant motivator for all the students, and he's teachers, even teachers of teachers. He's there with the rich academic experience, and he is always ready for the knowledge sharing. So today this session was planned actually on the like a mind behind that was Baldev sir only. So I thank Baldev sir for planning this OSCE stations session for helping our DNB students, which is very much required. 4 participants are there as a main participants because we need some participants to be there. Other participants also can join and take the participation in discussion. But we have Dr. Rajat from GMC Goa. Welcome, Rajat. We have Dr. Sayan Das and Dr. Mayur Gwalani from GMERS Gandhinagar. Welcome, Sayan and Mayur. And we have Dr. Dhaval from GMERS Sola. These 4 will be the main participants. All others, it was a very good response from all the students. But may I request all the students to please switch on your video. Because if you are not visible, then it's not like we don't enjoy interacting. Sir will also not enjoy interacting. You know, wherever there is the Viva, then the person should be visible. So all the students who wants to interact, please switch on your video. By this, sir, platform is yours.
Good evening, ma'am. Good evening, sir.
Good evening.
Good evening. Good evening.
Good evening, sir.
Good evening. Thank you very much, Dr. Nehal. I would like to appreciate Dr. Nehal that in spite of she is far away from the place with even the Pedicon, but still she have managed to start the session at least. It shows that how much she is interested in this academics. Still, I would like to appreciate that your gesture. I think before I start to share this PPT, let me make the points clear. Please, number 1, make your videos on. And second, try to participate. I have decided not to go for the monologue. That just I put something, some questions, and I will answer and will go. That is, I will say, not the interesting way. You can try to answer. And never bother that whether your answer is right or wrong. Even we'll try, and it's same thing happens even in the exams also. So we have not to worry. The only thing that we'll try to participate. And for that reason, multiple students are there on the screen. What I will request that if you want to answer, just raise your finger so that I come to know. And you know that order can be maintained. So for that purpose, another thing I have selected, I have so many presentations for this purpose. I have conducted other places, even DNB examiner for probably more than 10, 15 years, for MD examination, more than 35 years at different places across the country. And I have also learned that what are the problems or mistakes on the student side, how we can try to rectify it so that it can be useful to you in the exam. Number 1, always try to answer. Your answer may be wrong. It does not make much difference. But at least you are trying to think, you are responding, many times what happens that the student does not speak at all. And then it becomes a problem for this examiner. For OSCE also, that they are selecting the stations. All these things, whether it is the OSCE, whether it is the spot, whether it is the Viva, whether it is the case, at different places, the different questions can come. So format may be the different, but probably your answer or understanding may be almost the same. Keeping in mind the common situations I have selected, keeping in mind particularly the DNV OSCE stations. And the OSCE stations, what happens that very specific time is given for each station. During that time, you'll have to see the picture or some questions. You'll have to think and answer in the answer book. And you must be knowing that answer books are scanned by the center and it should be submitted immediately within the defined time at this center DNB office. And their assessment takes place. So it's very important. Fortunately, till there is no negative marking. So I think that's a good point. And keeping in mind, I have selected, not many questions are there. I think it requires we may go for one more session before your examination so that maximum we can cover the various topics and various formats of the DNP stations. With this remark, let me start to share this presentation and we'll start this discussion. I hope that my slide is seen. Are you able to see the slide, Rajat?
Yes, sir.
Okay, and I'm sure that I'm audible. I have not arranged with some system also because in the exam also that is not going to be that demarcation. And therefore you don't know that from which system. Therefore purposefully I have not arranged the system wise. Because that also will give you some hint. But in the exam you are not going to that hint. That's why I selected randomly. Let me start with this picture. Here is a 2-year-old child and presented with edema, hair changes, and these skin lesions. I started with the very basics. My first question, anybody, what is the diagnosis?
Sir, this is flaky paint dermatosis and crazy pigment appearance, which are seen in kwashiorkor.
Okay, very good. Now, with this question, what are the essential or cardinal features of kwashiorkor? Even anybody. And plus, speak your name so that I come to know, because I will not be able to see you when I'm sharing the PPT. So what are the essential, that means very cardinal features of kwashiorkor? Unless they are there, we cannot say that it's kwashiorkor, because some other resembling conditions will be also having the same thing. Suppose acrodermatitis entropathica. So what are the cardinal features? Anybody?
Sir, may I?
Yes, yes. Please, your name.
Sir, Mayur.
Yes, yes, Mayur.
Sir, edema, retarded growth, and psychomotor changes.
Okay. I think most of the books has given these three, but please remember one more, muscle wasting. Not just with the edema, it starts with bilateral pedal edema, then may become the generalized growth failure and apathetic or psychopathetic, but never say the mental retardation, right? And muscle wasting, absolutely right. Next question. What are the characteristics of skin lesions in this condition? I think Rajat already described that it flaky paint. Here what happens that there is a hyperpigmentation. Over the extensor aspects, there will be the peeling of the skin and there may be the hyperpigmented some patches. As if there is some, I will say, on the wall, there are some patches of the color flecks have already fallen. Similarly, there is a crazy pigment. And even the sometimes ulceration, even petechial or ecchymosis can also be the same. The next question, what deficiencies cause these skin lesions? in the kwashiorkor, what deficiencies are responsible for the skin changes? Anybody?
That's iron micronutrient deficiencies like zinc, vitamin A.
Hmm? Very important for undergraduate, I will consider. For the postgraduate, tyrosine is very important. And niacin, of course, zinc is there, and multivitamins, even the B12, vitamin A, of course. Next question, what are the common sites of these skin lesions? I think obviously seen.
Extensor aspects, sir.
Yes, and buttocks, perineum, and
Extensor
thighs.
of the arms.
Yeah, so these are the common sites. And in this type of even you may get this patient of the malnutrition in the short case. Then also all these questions may be there for the discussion. Or they can put this as the picture in the, once even, I think 2 years back, the same, this presentation was there. That's why it came to my mind to select and to sensitize you. Anyway, let us go to the next. Again, the very basic. What does it show and what's the diagnosis? Who will take it?
Cyan biter spot vitamin A
Vitamin
deficiency.
A deficiency.
Okay, Syed, can you describe in details what is the bitter spot?
Sir, it's a dry, the temporal part of the cornea is a dry.
Right?
Uh,
it's a dry, scaly collection of the desquamated epithelium.
Yes, sir.
Commonly seen on the I would say lateral aspect or
Lateral.
temporal. Absolutely right. Absolutely. And of course, we know that's a characteristic of vitamin A deficiency. But very important question, what is the treatment of this deficiency? Suppose you decided that this is a vitamin A deficiency. So what is the therapeutic treatment of this deficiency? One person can take it, please.
Less than 6
sir,
months.
Yes, yes. One person, speak your name and then start to answer.
Sir, Rajat.
Yes, Rajat.
Sir, we give vitamin A in the on day 0, day 1, and day 28. In less than 1 year, the dose is 1 lakh international units. More than 1 year, it is 2 lakh international units.
Okay.
So, yeah, we can either give orals and exactly half the dose will be the IM dose.
Okay. Please remember the therapeutic dose. Less than 6 months, 50,000 units. 6 to 12 months, 1 lakh unit. And more than 1 year, 2 lakhs. This is doses. And 3 doses, first day, second next day, and third after 4 weeks. Absolutely right regarding the doses. This is a therapeutic dose. So I think we should be very clear. And even this can be even in a Viva they may ask, or vitamin A solution may be there on the table, or even in this type of the OSCE they can ask. One more question on the same. What is the prophylaxis program against nutritional blindness? This is something different, which we should know. It's not the same. Who will take it? Anybody? Even other students can also take. If you're anybody, Aditi, so many students are there. I request everybody.
Sir, Vision 2020. Vision.
Yes.
Vision 2020.
Sorry.
Sir, Vision 2020.
What is 2020 vision?
Sir, year 2020.
No, this is the prophylaxis program.
Vitamin A prophylaxis program, sir.
This is the prophylaxis program against nutritional blindness, which started in 1970. And later on, of course, some modifications have come. You are right. But at least you can start. Some modification will go later on.
So is it NPCB, National Program,
National Program for Control of Blindness?
Control of
Yeah.
Blindness?
Yes. Same. What is that program, Rajat? What is the doses? How many doses?
The program is
may
National Program against Prevention and Control of
This
Blindness.
is national program. I'm talking of national program.
sir, may
Yes, sir, please.
sir, in this first dose of vitamin A is introduced at 9 months of age
Okay.
with measles, and then every 6 months, 2 lakh international units is given orally up to 5 years of age total.
Okay, very
I
good.
think total 17 doses are there.
Okay, but be very precise. I think I'm sure that with the display will be clear. Number 1, age 6 to 59, that means 5 years.
Hmm.
First dose at 9 months is 1 lakh. Later on, you start with the 2 lakhs at the DPT booster, 15 to 18 months. And then every 6 months till the age of 5 years, and total will become the 9 doses. So please remember, number 1 is the age. The second point, remember that the first dose is 1 lakh. Then remember the 2 lakhs. And second dose at DPT with the booster. And then 6 monthly to the 5 years. I think, suppose this is the program, but some examiner in the Viva, suppose, because there is some modification recently came, that in particularly severely malnourished children or socially deprived children, this may be right, but not for all. And for that reason, there are some modified up to the age of 3 years, which comes to about 5 doses. So I think even, but still this is the program. You can keep in mind both the things. And I think according to the one's response from the examiner, you can modify it, right? But this is the National Prophylaxis Program against nutritional blind. This is the nutritional blindness. Okay, one more question on the same. Suppose if you are sitting in the OPD or you are in the ward, patient of the measles is hospitalized or severe acute malnutrition. The child has no any vitamin A deficiency manifestations, but the condition is measles and severe acute malnutrition. You know, they can these are the vulnerable conditions for vitamin A deficiency precipitation. So what dose and schedule should be given in this situation?
So
The same like vitamin A deficiency.
Okay. Yes,
On
somebody,
day 0, day 1 and day 28.
okay, somebody said, may I?
Sir,
So, yes,
Mayur.
yes, yeah, Mayur, please.
Ma'am, sir, in this it's same 0, 1, 14, but it is the dose is divided according to weight also. If the
Okay.
weight is less than 8 kg, then we can give 1 lakh international unit. If it is more than 8 kg, then 2 lakh international unit orally at first, second, and 14th day of illness.
Please purposefully I have kept these 3 situations for vitamin A. Therapeutic, National Prophylaxis Program, and child with the measles and severe acute malnutrition, but no deficiency. And there should not be any confusion. That's why I have kept this. And many a times in the Viva, so many examiners are asking. Please remember, less than 1 year, 1 lakh, older children 2 lakhs, and here consecutive 2 days only. Because here there is no vitamin A deficiency, so therapeutic will not go. And this is not the National Prophylaxis Program also. This is just to prevent the precipitation of vitamin A deficiency due to measles and severe acute malnutrition to protect the child. So these are the 3 situations, different situations I have taken, and I'm sure that you are clear. There should not be confusion. Okay, let us go further. Very simple. Sometimes they will ask that, what does it show? What actually person is trying to demonstrate? They may ask in the exam also, even to demonstrate, or these are the pictures even they keep for clinical science. Okay?
Fitting
Eating
edema, sir.
Okay, I think I have kept one more question. Pitting edema. But you know, for what time? Sorry, another already it has come. To be pressed to demonstrate this sign. This is for 30 seconds. And with the reference, same one more question. What are the common sites to demonstrate pitting edema?
Against any bony sign, sir, against any bony prominence like sheen of tibia,
Yeah.
and then lateral malleolus.
Okay, so I think rather the exam, your answer should be very precise and short. Best way is to say sheen of the tibia and malleolus, right?
Yes, sir.
Of course, you are right to bony prominence, but these are the common sites. One more question. 2 years female present with bilateral pedal pitting edema and mid upper arm circumference less than 11.5. What is your diagnosis?
severe acute malnutrition.
Absolutely.
Right.
The point here, what the examiner wants to ask, Rajat, what are the other criteria for severe acute malnutrition?
One is the weight for height, which is less than -3 standard deviation.
Yes.
mid upper arm circumference less than 11.5,
Yeah.
and bilateral pedal edema, any one of these three, if positive, we say it is same.
Absolutely. And this is very common question in malnutrition because there will be short case also. Then here somebody will ask mid upper arm circumference. Who can take it? First, please give your name. I want to ask the question. May not be in the, I will say, presentation. Very simple question, but I'm sure with the reference to this discussion, somebody is going to ask you.
Yes, sir.
Okay. Is it Mayur?
Yes, sir.
Okay. Mayur, where you will measure the mid upper arm circumference? Anatomically, can you tell me?
Yes, sir. Mid upper arm circumference is taken first acromion process and lateral condyle, the lateral condyle of that humerus, lateral the midway between acromion process and the
Is it lateral condyle? That's why I'm asking. And this is
Yes,
common
sir.
mistake by the students. Acromion process is the part of which bone?
Scapula.
Scapula. And lower point is olecranon process.
Olecranon process. Yes, sir.
And olecranon process is the part of which bone?
Sign ulnar.
Humerus.
Ulna.
Sorry, ulna.
Okay, so draw the line and midpoint you can take for mid upper arm circumference. Somebody will ask what is the normal?
Normal is more than 11.5 to 12.5.
More than 12.5.
Okay, let the different answers come, then I will give the final.
13 more than 13.5.
13.5.
Okay, and what is the age? What age is selected for this? This is not for all the
1 to
ages.
5 years.
6 months to 5 years. No?
1 to 5 years.
Yeah. 6 months to 5 years is correct answer. 6 months to 5 years.
Sir,
And usually it is more than 13.5. Commonly in a healthy child, it may be 15, 16 centimeters. Less than 13 is abnormal, right? And the 13.5 to 12.5 mild, 12.5 to 11.5 moderate, and less than 11.5 centimeter considered as severe acute malnutrition. So that's the point. Yes, Rajat, you had some question?
sir, for the normal circumference, should we say it is 15 to 16 or more than 13.5 is enough?
Yeah, I think at least above 13.5 we consider normal.
Okay.
But commonly it may be 15, 16 centimeters, commonly healthy children. Right? Okay. Then I think just to remind you, somebody asked the Shakib strip, right? What is the Bengal ring? In the Bengal ring, you know, anybody knows what is the Bengal ring?
Sir, the Bengal ring in that, sir, it is one of the.
Yes.
Sir, a bangle is pushed towards the hand. If a child is having a severe acute malnutrition, that bangle will crosses that knee joint and it goes towards the upper side. So that suggests that
Which joint?
elbow joint.
Elbow.
Yeah, elbow.
Elbow joint.
Yeah, and what is the internal diameter of that Bengal ring?
4 centimeters.
Yeah, 4 centimeters.
4 centimeters.
So please keep, these are going to be that, I will say, Viva questions on your table. Okay, here, somebody trying to demonstrate over abdominal wall in a case of nephrotic syndrome. What does he want to check for? This is for somebody is going to ask in the question even the patient of nephrotic syndrome, short case. What he is trying to show, the abdominal wall, you can see that how he's demonstrating.
Sir, skin pinch.
Skin pinch for?
Abdominal
Any
wall
ascites, ascites or not?
You know, here is the patient of nephrotic syndrome. Therefore, you know, it would be
Abdominal wall,
generalized.
any edema or any ascites?
So edema where?
Abdominal wall edema.
Yeah, this is not the ascites sign. This is for the abdominal wall edema. Yeah, somebody is going to ask you that demonstrate for the abdominal wall edema. And how it is to be done, for what time one should pinch the skin over abdomen to check for abdominal wall edema?
30 seconds, sir.
Okay. Multiple choice questions. One is 30. Any more answers?
15 seconds, 10 to 15 seconds.
Okay. Correct answer is 10 seconds. And after the 10 seconds, what you will get so that you can say that yes, it is demonstrating abdominal wall edema.
It should be released back to the side, sir, less than 3 seconds.
That is it this abdominal wall edema or it is for something else? That's why I ask you. In the skin pinch,
The
that is for dehydration. That is for dehydration.
How it recoil back, sir? That impression, any impression is there or not?
Yeah, there will be the indentation or there will be the pits. Suppose no edema, then it will be in the original position. So in a nephrotic syndrome, many a times abdominal wall edema is common. And therefore, somebody will ask to demonstrate if it is there. So that's the thing that how best we can do. What I wanted to share with you, that these type of the signs, in a case they may say for demonstration, or in the OSCE station, they are even putting these type of the pictures and they can frame these type of the questions which should be clear. Okay, this was the 2 year. I have changed the different type of the formats because different formats are there in the OSCE stations. So I wanted to sensitize you that different type of the stations can be there. Here is a different way. X-ray. The 2-year-old child presented with high-grade fever, toxic loop, and right midsection pneumonia following measles. Now the child deteriorated after 5 days of hospitalization. And this was the repeat chest X-ray. I hope that you are able to see the picture. Now the questions, what does it show?
So nematocysts.
Okay. Nematocele, anything else beyond that? Is it only nematocele or something else even? If you see,
Nematocele with collapse of.
if you see, this is the whole wall. This is the destruction. Nematocele, I agreed with you. But this is even the opacity also, that whole cavity. And therefore, it is the right with the lung abscess. So this is necrotizing pneumonia leading to lung abscess. Now the next question, what is the most common organism? Because it is following measles. What is the most common organism?
Streptococcus pneumoniae.
Following these measles, most common is staphylococcal. Most staphylococcal. And therefore, what will be your choice of antibiotic? That will be the question. What should be your choice of antibiotics? I think here somebody give the different choices. Examiner may not mind. The only thing you should have the explanation.
The third generation cephalosporins.
You know which one?
Or penicillin group.
Third, you said staphylococcal aureus. Targeting staphylococcal, whether the third gen cephalosporin will be covering, is it the anti-staphylococcal? So you will have to go for choice of anti-staphylococcal. Yes, somebody was speaking.
Amoxicillin.
Amoxicillin is not anti-staphylococcal. It is covering mainly the gram-positive organisms. It is drug of choice for the streptococcal.
Vancomycin, sir.
Here, second thing, necrotizing pneumonia is a serious condition. So we will have to go for very appropriate staphylococcal agent. And for that reason, if somebody goes ceftriaxone, vancomycin, that will be good because streptococcal also can be covered by the ceftriaxone. Somebody goes even amoxicillin and vancomycin, that will be also fair. Even somebody goes for ceftriaxone and cloxacillin, not wrong. The point is, you are able to give the justification, but at least very good effective anti-staphylococcal agent should be there. And in a case of lung abscess, I would say vancomycin containing regime is more appropriate. Okay, and these type of questions are very common. Okay, one more. This is just picture. You can see the picture. I remember in one of the exams, Ambedkar sir was there, and sir asked the student to draw this picture even. And in one of the OSCE, this picture was there. To remind you, I have kept the picture in this slide also. Now the questions. What this picture shows?
Sir, it's a growth velocity curve showing
good.
the
Very good, very good, very good.
Growth spurt.
pivotal height velocity.
You know, this is the growth velocity curve. Very important answer, very good answer. And here, then the question will be, what is the rate of increase in height at different ages? Suppose 1 year. What will be the rate of increase in height or length?
So 25 centimeters per year in the first year.
Okay.
Then it is around 12 centimeters per year from 1 to 2 years.
Absolutely.
So then it is 8 to 10
Point.
centimeter, 6 to 8 centimeter, 6 to 10 centimeters per year,
Okay.
till the age of 6.
Okay, please remember this one. Rajat has answered some of the good points. First year, 25 centimeter. Second year, 12 centimeter. Third year, 6 centimeter. And later on, 5 centimeter per year till puberty. I think what is the importance in further questions, I will take it. What is the growth velocity in boys during puberty? During puberty. You can see here that this is the puberty time. Here you know that the maximum growth rate of increase in the height is maximum in the infancy. Then gradually rate of increase decreases, remains even some static for some time. And at the puberty around 10 years, there is the spurt. And again, it gradually slows down for 16 to 18 years. The boys 18 years. And here this is the difference in the girls and boys. Here, what was my question? The growth velocity in boys during puberty time.
So 10 to 12
10 to 12 centimeter per year.
Okay. Please remember 9.5 centimeter per year in boys. 10 centimeter is not the wrong answer. That is in the boys. In the girls, 8.3 centimeter per year. And please remember, boys have 2 years longer duration of pubertal growth than the girls. And therefore, the boys are attaining more height than the girls. And for that reason, you know, mid-parental height plus 13 minus 13 point has come. So this is particularly with the reference to growth velocity in the boys and girls. So this is very important with the reference to growth charts. And at least one station, OSCE station is going to be there on the growth chart. Commonly, most of the time they keep it at least one. So let us go some of the examples which I have taken. This is another growth chart. Here the 10 years old boy, weight is 23, height is 123. Mid-parental height is calculated. Now weightage is 8 years. You can see this is the weight. And that 50th percentile, and if you see it comes to 8 years. This is the height and that also 50th percentile if you come in 8 years. So, and somebody has gone for the skeletal age, bone age, that is also 8 years. So chronological age is 10 years, but weight, height and bone all are 8 years. My question is, arrange in the ascending order. That will give you the idea that what is the problem.
Sir, science chronological age greater than height age equal to bone age, mostly constitutional growth delay.
Who is speaking?
Science, sir.
And very good, very good. You know, if we see that weight, height and bone, they are equally. But compared to chronological age, they are behind. And that gives a very clear impression that this is the constitutional delay. And you know, here the question will come, what point in the history may be favoring your diagnosis? And
Mid-parental height, sir.
what point in the history?
So delay puberty among the family members.
Absolutely.
At what age means the growth velocity?
Yeah, the point is, you know, history of delayed puberty in either parents. Now, if you ask the mother, she will say that her menarche was late. or even the father that he started to shave the beard late compared to even his some relative or brother or so, or even his classmate. So this is the history of delayed puberty, this type of growth, and this will be the very strong point. Now the next question with that, what investigations you will perform?
So just to rule out any other causes like hypothyroidism and endocrine causes.
I think already you defined the
any
cause.
X-rays.
Sir, actually, there is no need for
Any
investigation. Just
hormonal sir.
observe the growth
Any hormone
velocity on the.
Very good answer, Rajat. And you know, please, why we are insisting so much on the growth chart? Unnecessary investigations can be avoided. Because if you suppose somebody goes for the growth hormone, you know, it's a pulsatile variable growth hormone estimation. It comes suppose lower, little bit low if you are done in the afternoon or evening, then you will consider the growth hormone deficiency. But here there is no need to investigations because already you say constitutional delay. But the point is very right to point that assurance and follow the growth velocity. After 6 months, see that how much the child is growing. The growth velocity will be according to these. Suppose in the 6 months, there may be the increase of about 5 centimeter, 4 to 5 centimeter, then it's good. Then go again for after 6 months. Then I think in a 8-10 centimeters, suppose increase in 1 year, that confirms your diagnosis. There is no need to go anything. And at the end of puberty, 18 years, child is going to attain this very good growth. So, you know, this is the point. If you are understood, even in the exam or at any other place, you can answer very appropriately. Therefore, purposefully, I have taken some of the conditions. Okay, let us go further. One more, I would say, growth chart. This is 5.5 years old boy. Weight is 12, height is 99. Now, if you see the weightage, which is already shown over here, comes to about 2.5. And height is, if you see, it comes to 4. So the question is, already answer has also come. Arrange the chronology. So that means, you know, the chronological age is more. Height is less, but the weight is still less. Then what does it indicate? What does it suggest?
Malnutrition.
Most likely cause is malnutrition.
Very good, very good. Any more adjective with the malnutrition? Can you say? Because height is less affected compared to weight.
Acute on chronic.
Therefore, it is acute on chronic.
Acute.
You know, both are affected, but the weight is more affected compared to the height. That it becomes fair. And you know, age is 5 years. That's why I kept. What is the common age for the malnutrition? 6 months to 5 years. So look at the age also. That 6 months to age 5 years. And if you have suppose previous readings, that will confirm that when it started. So this is the thing which I wanted to share with you. One more growth chart. This is 10 years old female. Weight is 22, height is 110. Mid-parental height you can see. Now the weightage is, if you see weightage here, it's 8.5. And height is here, it is 5.5, 5.75. Somebody has gone for skeletal age, it is 5.5. With this interpretation, my question, arrange the chronological age, height age, bone age, and weight age in order.
So chronological age more than weightage, more than height age, which is more than bone age.
Okay, so what is your interpretation?
Pathological.
Familial short stature.
Endocrine causes.
Now look at this, height is affected. Yes, significantly affected. Weight is affected. Yes, but less affected. And height age and bone age almost similar. You know, another principle, remember, most of the times height age and bone age are corresponding. So here they are almost equal. That means in which condition height will be more affected?
Familiar short
Yeah,
stature.
now
Familiar short stature.
here, if you say bone and
endocrine
height,
causes, sir, like thyroid disorders.
yeah, that's good. That's good. Any condition where height is more affected, that condition requires the investigations for endocrinal cause. And here, if you see bone and height, they are equal, right? And they are more affected compared to weight. And even weight is less for that chronological age. And therefore, this is very classical endocrine disorder. So find out that compared to even the weight, height is more affected. That is very classical example of endocrine disorder. And there may be the hypothyroidism, endocrine, and even adrenal gland may require the investigations. One more probably condition. This was 4.5 years old female child. Weight is 15, height is 110. But if you see the weightage, this is here the weightage. Sorry, I'm trying to catch the cursor. Yes, this comes to almost 3.75. And if you see, this is the height, is 5.5. And bone age is 6.5. Did you get the point? Now, if I ask the question,
Yes, sir.
to arrange them in order, see the chronology age is 4.5.
Bone age is more than chronological age.
For that height is advanced. Height and bone, both height and bone is more advanced. But weight is less. So what does it indicate?
Precocious puberty.
Precocious puberty.
Very good, very good, very good. I will appreciate. That means you are really prepared. In precocious puberty, you know the height is advanced, accelerated. And that is very classical for the precocious puberty. And here it requires the further workup again. One more. I think here I kept this is the initial readings were there for all the head, weight, weight and height. And this is later on. Then I will put the question. Interpret these two growth chart. What they show?
The weight, height, BMI.
If you see here, suppose first try to interpret the first top one. I will say this one. This is since birth taken, all these readings. This is the head. This is the weight.
So we can say that though initially the child began with malnutrition, but
So
slowly
maybe
the child is catching up with the nutritional status.
Very good. Then in which situation it will happen?
Catching up
Very
preterm or
good.
IUCD
Very good.
catching up.
Very
First
good.
growth chart.
preterms.
Very good. The only point what will be there, Rajat, in the exam, here I am trying to give some hint or showing the points. In the exam, nobody will show. You will have to interpret. So the point is absolutely right that at birth, weight, length, and head all were low. So either the baby may be the preterm or low birth weight. But if you see that the head is growing faster, you can see here the head is going faster. Then the weight and length is still slower. And second growth chart shows that yes, head has reached. And even this weight and height is reaching at last. And therefore the question will be, what is the pattern of catch-up growth? Please remember catch-up growth. Head circumference will reach to the expected at 18 months. That means you can compare with other child, normal child. And weight by 2 years. And height is attained late by 40 months. So this is catch-up growth. But in some of the, I think, I don't remember the percentage, but some 20% or so, they may not have the catch-up growth. And in that case, we'll have to go in the details. So this is the, in short, various growth charts I have taken. it should be clear. And one type of growth chart, either in the OSCE station. Nowadays, even they are keeping on the Viva table also. This type of the prepared growth chart, they may come to you. And they will give the growth chart and then they will say that they interpret. And I think this is the exercise. Now let us go further. Some different type of the questions. An 8-year-old boy developed swelling of lips suddenly following eating chikki on Makar Sankranti containing nuts. He developed the severe swelling of eyelids, lips and neck and stridor even within 2 hours of onset of symptoms. There is history of similar problem to the sibling also. You can see the picture. Child is not able to open the eyes at all. And this is real, real I will say, case which I have seen.
Angioedema.
Yeah,
Hereditary angioedema.
Hereditary angioedema.
In the question, what type of the immune reaction is it?
Type 1 hypersensitivity.
Type 1 hypersensitivity.
Very good, very good. It is a type 1 hypersensitivity. And then the third question, which is very important, what is the investigation of choice for hereditary angioedema?
Complementary level C3.
Okay, C3 or some other?
IgE.
C1
eosinophil.
C1
IgE
levels
level
complement
eosinophil.
This complement C4 for hereditary angioedema I'm talking. And
C1
hereditary.
C1 esterase inhibitor.
Yeah, C1 esterase inhibitor. These are the investigations. And very important question, which drugs are life-saving?
Epinephrine.
Yes?
Adrenaline.
Adrenaline. Anything else?
Hydrocortisone.
Okay.
Hydrocortisone.
And phenyramine.
Avil.
Please remember here, type 1 hypersensitivity is with the liberation of what substance?
Histamine.
Oh, that's the point. And therefore, the very important drug after this antihistaminic. Even if the child is able to take orally, give the orally. And later on the steroids. But the order should be like this. Epinephrine should come first. Then the antihistaminic, then the steroids, and then of course supportive therapy. And this type of picture, at least some emergency, they will keep it. Because they want to assess that have you worked in the ward with some emergency case. They may keep here some diabetic ketoacidosis. They will keep some anaphylactic reaction. They will keep here some status asthmaticus. So these type of some emergency, at least they will select. And with a reference to that various questions, people can frame. Okay, one more picture. These nodules were found over occiput in 12-year-old boy suffering from acquired heart disease. My question is,
subcutaneous nodule rheumatic heart disease.
Okay, this is subcutaneous nodules. Very classical. But the next question, which
RHD, rheumatic heart disease.
Please don't say rheumatic heart disease. It is acute rheumatic fever. Because you know, rheumatic heart disease is a consequence damage
of acute rheumatic fever
to these valves following this rheumatic fever. So it's an acute rheumatic fever. Okay, one more question. Describe exactly what is the description of these lesions.
So these are usually tender nodules present usually over the extensor aspect.
Right.
Form consistency.
Okay.
And they were initially before known as poor man's ECGs because presence of subacute nodules suggests presence of carditis.
Okay.
Please describe.
It is
yes.
Painless.
Absolutely, absolutely.
Painless.
These are not tender. So nodules of varying size. Size is from pinhead to the almond size. And Rajat, they are non-tender. This is a very important point which we can remember. And absolutely you were right that common of the bony prominences. Sheen of the tibia, wrist, elbow, knee, ankle, spine, and even the occiput. These are the common sites. But the next question, What is the importance of their presence in rheumatic fever? What does it indicate? What does it suggest?
So presence of subcutaneous nodules
Underlying carditis.
always suggests presence of carditis. So we have to see for carditis, look out for carditis in case
Very
subcu
good.
nodules.
Very good. Anything else? One more point. Because these are, important
Chorea.
marker in the rheumatic. Chorea
Sir,
is
ash of
different.
bodies.
Ash of nodules is different. That
Sir,
is
risk of CHD in later life.
okay. These are the 2 points with the nodules. One, the rheumatic fever with carditis is very good. But persistence of nodule is associated with chronic carditis. And chronic carditis is having the not good prognosis. That is the point. Fortunately, now rheumatic fever has come down very significantly the way in which we used to see. But when I talk to the pediatric cardiologists, suppose in the UN Mehta, they say that they are getting the patients. So this type of and suppose even there may be the patient of the rheumatic mitral stenosis or something, they may keep as a short case. Okay, this is very important picture. This was the infant presented with this swelling. This is the swelling over the thigh, left thigh, following DPT whole cell vaccination. What is it? What type of the problem it is?
Abscess.
Abscess.
Bleeding disorder,
reaction.
maybe hemophilia.
Local site reaction.
Sorry?
So
Local, yes,
local
sir,
site
local site
reaction
reaction.
post-vaccine.
What is local reaction?
So inflammation of
Type
the
2.
subcutaneous tissues and
Due to?
Our immune system acting against the DTP virus, bacteria.
The
Okay.
cellular components are reacting.
Who is speaking? May I know?
Science.
Yes, one is Sayan, another person was also speaking. Okay. The point is, this had developed within few hours. So it is not abscess. This is not even some bleeding disorder. Somebody was pointing out is good differential diagnosis. But in that case, there is a hematoma. The hematoma picture will be quite different. It will be not elevated over the thigh. It will be on the contrary deep mass in the muscles. So this is not the bleeding disorder. This is not the abscess formation. And this is the type 3 Arthus phenomena, immune complex disease. This is type 3 immune reaction. And here, what are the absolute contraindications of DPT vaccination? Somebody will ask in this way. What are the absolute contraindications? Where you should not go for the
Severe
DPT?
life-threatening reaction to the previous DPT vaccine.
Okay, very
Those-
good. Very
then
good.
children with neurological disorders and epilepsy for
Progressive
No, no.
neurological disorder,
Sir,
sir.
may
pertussis.
Rajat, it is
Sir,
not the contraindication. Any
sir,
neurological
absolute
That's an absorbent
progr
reaction.
no, sir. One absolute that progressive neurodegenerative disorders are
Okay.
contraindicated for DPT. And
Okay.
second, any reaction previously anaphylaxis reaction noted due to DPT vaccination can be
Right.
the absolute contraindication. Two things.
Okay. Okay. Third, very important, related to only DPT.
Local
Very good. Who said? I think some ladies spoke. May I know the
Encephalopathy.
name?
Yeah.
Encephalopathy. Who said? I want to know the name of the person. No problem. I think some lady voice was there. Rajat? Hello?
Yes, sir.
Yes, sir.
I think there was some network issue.
No, sir.
No,
We are
sir.
able to listen.
Okay. Am I audible?
Yes, sir.
Yes,
Yes, sir. Yes,
Okay,
sir.
okay. Because there was no response from your side. That's why. There was some, I will say, female voice. That's why I asked who said the encephalopathy.
Sir, actually, progressive encephalopathy
Okay. Answer is, severe allergic reaction to vaccine component following prior doses. That is very important. Pertussis encephalopathy. Encephalopathy due to the pertussis and even anaphylaxis. Of course, neurological conditions are relative. They are not absolute contraindication, except some degenerative disorders, okay. Otherwise, cerebral palsy and other conditions are febrile seizures, they are not contraindications. One more question the DPT somebody is going to ask, what are the considered precautions, but not the contraindications? Some people don't give the vaccine due to these problems. That is not right. What are they? Anybody?
Immunodeficiency disorder like HIV.
Okay.
Yeah, patient on corticosteroid therapy due to McCormick syndrome.
Immunosuppressants.
Okay, what precautions you are going to take in that case? Here they say that you can take the precautions, but don't deprive the child from DPT vaccine.
So we can further delay the vaccination from 6 months around.
Here that means some problem developed to the child with the DPT. But that problem should not become the contraindication. You can take care and go for the further vaccination. That's the point.
History of
Febrile
febrile
seizures,
Any
inconceivable
anxiety?
cry.
Yeah. Then, sir, parental hesitancy.
Sorry,
Parental hesitancy.
your voice is breaking.
Parental hesitancy, sir.
Parental?
Hesitancy.
Hesitancy, sir, he said hesitancy. Hesitant parent to give the vaccine.
Oh, that's the point. Please remember, these are the points. Persistent, inconceivable crying for more than 3 hours. Many times it happens with the DPT, but you can take the precaution, but don't stop to give the DPT. Second, hyperpyrexia. Third, that hypotonic, hyporesponsive episode. Within 48 hours, some children develop, or febrile seizures. Even following DPT, febrile seizures happen so, but it is not the contraindication. You can go for even the prophylaxis clobazam and give even this DPT. So that's the point with the DPT vaccination. And therefore, any one vaccine can be many a time the OSCE station. Either they may take some indication, they may take some this type of complication or something else. But the one vaccine question, OSCE station, commonly they keep it. Okay, one more picture. An infant presented with severe anemia, regression of motor milestone, irritability, and vacant flu. What is your diagnosis?
Vitamin B12 deficiency.
Deficiency.
What is the condition?
Infantile tremor syndrome.
Infantile tremor syndrome.
Infantile tremor syndrome.
Condition is infantile tremor or anemia tremor syndrome. Of course, the deficiency, somebody said right,
B12,
iron,
folic
B12
acid,
and
iron.
folic acid. And what are the treatment components? All these you should know.
Supplements.
Sometimes infantile tremor syndrome with the patient is there, they may keep as a short case. And then they will ask, with the treatment, most of the children do recover. Sometimes this was classified as degenerative disorder, but now it's not degenerative. There is a fully recovered. And this is more common somehow in India subcontinent. So that's a common condition. Therefore, we should know the infantile tremor syndrome. One more question. They are keeping these type of some specimens. Here is the 8-year-old girl presented with fever, pallor, and jaundice of acute onset. And this was the color of her urine. She had fever and cough cold 2 weeks back. Now the question is, what is your diagnosis?
PSG.
PNH.
AG.
IgA nephropathy.
Sorry?
IgA nephropathy.
Post-infectious glomerular.
Post-infectious
AGN.
glomerulonephritis.
If a child is having fever, severe pallor, and jaundice, and of acute
H3
onset,
deficiency.
Hemolytic anemia.
Hemolytic.
Political.
PSGN.
this is post-streptococcal. It's a late complication of streptococcal infection. Patient does not present with the fever. Second thing, these children don't develop the pallor and even the jaundice. They can develop the hematuria, but not the jaundice.
Hemolytic uremic syndrome.
Hemolytic.
Hemolytic uremic syndrome is following most commonly
Coli
diarrhea.
infection.
But most commonly diarrhea, dysentery.
But
Here,
yes,
this
sir,
was the
it can
cork.
happen after pneumonia infection too.
Here it was the cope call. And following that, this complication, that hemolytic anemia, but with a fever, and of acute onset within even few days. And this is the autoimmune
Autoimmune hemolytic anemia.
Please remember, not uncommon. Autoimmune hemolytic anemia. And somebody will ask that, what does this color of the urine indicate? This color is due to what?
Hemolysis of the
Hemoglobin,
RBCs.
presence of hemoglobin.
Hemoglobin. Sir.
Hemolysis of the RBCs.
Very
Hemoglobin.
good. Very good. This is due to hemoglobinuria.
Hemoglobinuria.
If you go for urine examination, it does not show the hematuria, not RBC. But this color will be there. That's a very important point. And third point, what are the investigations for autoimmune hemolytic anemia?
So Coombs test.
Coombs,
Very
directly.
good.
Coombs
Very
test.
good. What the peripheral smear will show?
So
Was
cystocytes and sometimes
Bicep.
phagocytosis.
Bite cells.
Yeah,
Phagocytosis.
spirocytosis is the characteristic. By the spirocytosis, you know that
because some part of membrane is eaten.
Yeah, very good. And when this particular RBC is passing through the spleen, one layer is taken up, and therefore the cell goes for the swelling, and therefore appearing like spirocytes. So CBC will show the low hemoglobin because hemolysis. But count and platelets may be normal. Sometimes platelets can be low even due to immune mechanism. Peripheral smear examination very important. Polychromasia and reticulocytosis due to the hemolysis. Spirocytosis. WBC and platelets may be normal, and Coombs test is very, very important. Direct Coombs test will be positive. And other causes of red color urine, sometimes we should keep in mind that pigmentation in the food, when the beetroots, urates, some drugs like rifampicin, pyridium. Yeah. So these are the questions. Now they may keep some specimen. Sometimes even the CSF, or even these types of urine, or even some peripheral smear with the specific RBC or acanthocytes or something like that, or even malarial parasites. Yes, they can keep the malarial parasites in the smear. So these type of some investigations which they can keep in the OSCE station. And commonly they select different, that's why I have also selected that you are exposed to the various type of these stations so that you can have the idea. Very simple.
Finger pulse oxy.
Yeah. What does it detect? It's like, yeah. So it detects the hypoxemia.
Heart rate and oxygen concentration.
Concentration, yes. Now, what level of SpO2 in room air indicates adequate oxygenation?
More than 94%.
92%.
Very good, very good. 94, 95, okay. Then the third question, at what SpO2 level it indicates oxygen therapy?
Less than 92%.
Less than 90.
Very good. Even at least less than 90, certainly. 92, you should be very cautious. And at what level of the SpO2 cyanosis even develops clinically? Suppose clinically cyanosis, that means SpO2 is less than this much, you can say.
60%.
80%.
SpO2 is less than 60%.
Very good. No, 60 is too low, less than 80%.
80%.
Some people say 85, but 85%. Clinically cyanosis, that means SpO2 is definitely around 85, at least less than 80. So, you know, the simple questions they can ask, even this type of instrument, they will keep one instrument also they are keeping in the OSCE station. Now, the next question, Ivan, what are the limitations of this instrument, pulse oximetry?
If patient have nail polish on
Meth
the
hemoglobin.
then it cannot detect the
from the
saturation appropriately.
Sir,
Movement
sorry,
error रह सकता है.
Okay,
sir, it cannot correlate with the arterial oxygen level.
right. It is right.
So then it is subject to motion blur, like if the patient is moving, the saturation levels may fluctuate.
Okay. You know,
And-
but, okay. You know,
and-
what happens sometimes that due to some error, your reading is wrong. And that is, you know, poor peripheral perfusion.
Okay.
When the patient presents you with a poor peripheral perfusion, in spite of good oxygenation, your pulse oximeter will show the low. Even simple due to the suppose cold extremities, due to the air condition, in the NICU, many times it happens so. Even in a case of anemia, severe anemia, methemoglobinemia will show the SpO2 normal. Even carboxyhemoglobin, that will misguide you. So the point is, you know, poor peripheral perfusion, anemia, methemoglobinemia, carboxyhemoglobinemia, that will misguide you. That are the limitations where your interpretation may not be right. So that's the point which we should consider. Let us go further. Some case scenario. Very common case scenario. 11 years old male child was admitted for jaundice and high colored urine for 3 months duration. Clinically vital, stable, febrile. Ictus was noted, no pallor, no lymphadenopathy. Liver was enlarged, form inconsistency, spleen was also enlarged. Eye examination was contributory. Bilirubin was 4.5 direct type. Some enzymatic reaction, coagulation profile, seromarkers for viral hepatitis, normal. Child was born of a consequence parents and his elder sister died at the age of due to the similar illness. I think very common condition.
Wilson's disease.
Wilson disease. Science.
Absolutely, it is
Wilson
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 disease.
disease.
Wilson disease. Please remember. And here, what will be finding on eye?
Around
Pressure ring.
KF ring.
KF ring. And KF ring can be seen with the naked eye.
No, sir. Slit light exam.
No.
It can be, sir. Sometimes
It can be seen.
It can be
Yeah.
seen if full
It can be
developed.
seen.
Then can
The point is, KF ring can be seen even naked eye, but suppose if it is not seen, confirmed by the slit lamp examination before you say it is not seen.
Mhm.
So that's the point regarding the KF ring. Name the 3 confirmatory laboratory investigations for your Wilson.
Serum,
24
So
hour
one is serum ceruloplasmin,
Okay,
urinary copper,
very good.
24 hours.
Very
And
good.
liver
and
liver
the gold standard, sir, they are
copper.
saying the liver copper content per gram
Yeah.
of liver tissue, how much copper is.
Please remember the figures. Serum ceruloplasmin less than 20 milligram per deciliter. Urinary copper excretion more than 100 microgram per day, but very often it is more than 1000 microgram per day. Urinary copper. And third, very important, I will say, or more reliable, is hepatic copper content. And that is more than 250 microgram per gram of the dry weight of the tissue, dry weight. So these are the 3 very important confirmatory, I will say, investigations for Wilson. At any time in the Viva, so many places, even the case they can ask you. Specific treatment of the condition.
Liver transplant.
D-penicillamine.
And penicillamine.
Drugs,
What is the dose? Dose. D-penicillamine dose is 20 milligram per kg per day. And what is the very important toxicity of D-penicillamine?
Zinc deficiency.
That we are supplementing zinc for this purpose. Okay. But before that, or very important, even sometimes threatening complication. D-penicillamine.
Penicillin hypersensitivity.
Okay.
Again,
Any related?
Ophthalmic, sir.
Any related to kidney?
Nephrotic syndrome.
nephrotic.
Yeah, D-penicillamine is known to cause the nephrotic syndrome, so you should be very careful. And of course, restriction of copper. And dietary advice, that what you will advise not to take. You know, these are the questions are now very important in any case. And that is avoid the copper containing foods like liver, shellfish, nuts, chocolates. And avoid even the storing and cooking in copper or brass vessels. So this advice is also very, very important. And of course, counseling. Okay, one more. This was 6 years old boy finding difficulty while getting up. It is shown in the picture. He has to take the support.
Gover signs.
Gover sign.
Gover sign.
Okay, this is
Ductal
Gover
muscular
sign. Gover
dystrophy.
sign. Now the next question, very important. At what age this sign is fully expressed?
Pre-pubertal, sir, 12 years old.
And at what age it may be evident? That means you
5
can
to 6
suspect.
years. Say 5 to 6 years it is usually evident, and by 10 years it is
10.
fully expressed.
Anybody? That's why purposefully I kept, and this is very common. And you know, DMT may be the case even. Suppose the case is available, they are keeping it the short case. We
Sir,
have
eight-
also kept last time. So you know,
Sir,
if you
8
know,
to 10 years around it start developing, then
More than
around
3
13,
years.
14 years it expressed.
I think if you have seen the patient, you must have seen earlier also. I request even other students also to participate. Please speak. 5 years very easily fully expressed. And even early you may suspect at 2 to 3 years, 3 years. 3 years just taking the support. You are not sure. But 5 years fully, that it is mentioned in Menkes, Pediatric Clinical Neurology. And even Dr. Vrajesh Sudani frequently asking this question. What deficiency is responsible for this disease?
Dystrophin gene.
Very good, very good.
Dystrophin.
Very good, dystrophin. And which clinical syndrome in girls has been found with full clinical picture of this disease?
So girls with Turner syndrome.
Turner
or
syndrome
And-
or lionization.
Very good, very
Turner.
good, very good. You know, usually females will not develop, but this with Turner they can. And at what age usually they die? What
25
are the
years.
common causes?
Nearly
Second-
40 years
second
to
decade
Second
By
to
second
second.
decade, sir,
pneumonias.
by
15
Yeah.
years.
Usually
20 years.
18 to 20, after 15, 20. And
After
main
15.
problem is respiratory failure, or even cardiomyopathy and therefore cardiac failure, or even the airway obstruction. These are the common 3 causes for the death. So these are the questions they can ask you. This was 14 years old girl, had been brought with history of high-grade fever since 3 weeks and progressive breathlessness and swelling of feet. She had generalized seizures today. On presentation, she is drowsy but arousable. She has oral ulcers, arthritic both knees, pleural effusion, but no jaundice, no neck stiffness. Liver 4 cm below costal margin and 2D echo showed pericardial effusion. Very classical clinical picture. I had photograph also. I could not manage to put over here. But these are the case scenario, common case scenario they are keeping. What is the most probable diagnosis?
SLE.
Viral myocarditis.
Very good, very good. You know, if you see anything, 14 years girl, adolescent girl, that is most common age. Fever and progressive breathlessness, particularly, you know, seizures, that means that is vasculitis. Now ulcers, oral ulcers is a very characteristic. And then multi-system involvement. No neck stiffness, that means this is not not due to the meningitis, but due to vasculitis. And therefore, this is SLE.
Yes,
SL.
What are the confirmatory investigations for SLE?
Anti-DS
specific test
DNA.
would be anti-SLE antibodies.
Anti-DS DNA. And another very characteristic anti-Smith antibody. Of course, ANAN and others are there, but these are the very confirmatory. What hematological parameters are expected to be present in SLE? Hematological.
Anemia,
Pancytopenia.
thrombocytopenia, and leukopenia.
Thrombocytopenia.
Very good. You know, most of the connective tissue disorders, there is leukocytosis and thrombocytosis. But here in this patient, even there may be the hemolytic anemia with reticulocytosis, leukopenia, lymphopenia, and thrombocytopenia. I think here I have not mentioned, but what happens to ESR and CRP?
ESR is raised, sir.
Raised, sir.
And what happens to CRP?
CRP may be normal to low.
Why? Very good. Answer is right. But what is the explanation, Rajat? Very good.
It's not a
It's not the acute phase of
infectious disorders. It's a not an infectious disease.
Then why the ESR is raised?
Anemia induced, sir.
Acute phase reactants like interleukins and all.
Suppose acute phase reactant, there's CRP is also acute phase reactant.
CRP is acute positive acute phase reactant. It is a chronic disease.
Complement deficiency, sir.
Yes, I think whose voice I am not able to get it. Please.
Complement deficiency, sir.
Can you identify yourself?
I am Dr. Subhashri, sir.
Yeah, Subhashri, I will have to remember because in between you are answering very nicely. Please remember, this is the condition SLE where the ESR is rising and CRP is remaining normal or going down. Very, very rightly she answered to the complement disorder. You know what happens? Basically, the mechanism that with this inflammatory condition, particularly there is a problem with the complement, hypercomplement here. Complement is required for this CRP synthesis in liver. Now that pathway is blocked in SLE and therefore CRP is not rising. But SLE is inflammatory condition. You know, it is not infective but inflammatory. And in an inflammatory condition, acute phase reactants are going to be high. You know, in a case of juvenile idiopathic arthritis, ESR, CRP both are rising. But here, due to the complement block, CRP is not rising. And that becomes a very strong, I will say, point to you to suspect that this is SLE. This is the clinical picture. Now, in which condition CRP is rising and ESR is decreasing or going down? Another condition where CRP is rising, but ESR is going down.
Macrophage activation syndrome.
Very good. Can you identify yourself, please, again? I want to know the name of the students. Who answered?
Sagarika.
Yeah, Sagarika, very good. Oh, Sagarika, are you there?
Yes, sir.
You know, in what happens in this macrophage activation or HLH syndrome, HLH hemophagocytic lymphohistiocytosis, what happens? That fibrinogen is going down. Now you know for the Zolo formation and ESR, that is the erythrocyte sedimentation, fibrinogen is required. But now the fibrinogen is decreasing, going down. Therefore, ESR is going down, but CRP is rising. That is very classical picture of macrophage activation syndrome. In a case of connective tissue disorder, and in some other conditions, HLH. While in a case of the SLE, what we discussed, that ESR is rising, but the CRP is not rising or going down. This is very characteristic. And you know, this investigation pattern also they are keeping in one of the stations. Name the two drugs even which can lead to this condition, SLE. That means SLE is precipitated by the which drugs?
Penicillamine.
So drug-induced
sulfur drugs.
or isoniazid, procainamide.
Sulfonamides, sulfur drugs.
Common I mentioned.
AEDs and sulfur drugs, sir.
Yeah, phenytoin, sulfonamides, and the hydrolysine. Hydrolysine is now not used much. We were using for the antihypertensive and used to see some of the patients. So what I mean to say that these are the case scenario, maybe the one of these stations. Now even drugs, suppose methylene blue is kept. Name two indications of methylene blue.
Methemoglobinemia.
Okay, one is methemoglobinemia. Very good. Any more? Any?
Cyanide poisoning.
Yes, cyanide poisoning. It is the antidote. And drug-induced methemoglobinemia. You know, this may not be useful in the hereditary methemoglobinemia or congenital, but drug-induced, yes. Name the two contraindications where you should not use the methylene blue.
Hypersensitivity reactant.
G6PD deficiency.
Very good.
Anaphylaxis.
Very good. G6, where G6PD. Methylene blue usually does not cause much, I would say, side effects of the anaphylaxis. But the very important G6PD, and second is renal insufficiency. And third question, suppose if you have used, what is the color of the urine when the patient is given the methylene blue?
Cyan. Light bluish cyanish color.
And you should not. Okay. Some other answer was coming, please. Urine and even fecal matter turns out blue-green. And talk to the parents. And even this, suppose that means your methylene blue is working. And methylene blue even available, and this ampule may be kept in the table Viva also. Now, one more, these type the question, that medical treatment of cyanotic spare in a case of Fallus tetra, who will take it? One person, so that another person can add or something missed. One person can take it. First, identify yourself so that I come to know the names of the student, please. Yes, Raja.
So it's preferable to keep the child on the mother's lap, and so that the crying episodes, whatever has precipitated the spell, is resolved. Then then the knee chest position is favorable, and the drugs which we are using can either be propranolol, ketamine, or phenylephrine.
Okay.
And sometimes morphine also.
Right.
We can give oxygenation.
Oxygenation.
Very good.
Fluid boluses, metoprolol, sir.
Please, every time identify us, because you know I'm not able to see.
Science, sir. Oxygenation, then morphine, then fluid boluses, then metoprolol.
Very good.
And even IV phenylephrine can be given also.
Okay. Anybody else?
Sir, buprenorphine can be given, sir.
Please identify yourself.
Subhashri, sir. Subhashri.
Okay, Subhashri. You know, one point which I want your attention. In such type of the case, the chronology of the treatment should be very specific. The order, that this should be first, this should be second, this should be third. Because, you know, it makes difference in the management of the patient, and therefore purposefully they will ask this type of question. That not only just management, but the order should also be the right. And for that, very first is the position of the patient. At least if we say the position, that's all. Younger the child, you can keep in the lap of the mother, or even the older child, knee chest position. Second point should be the oxygen. And very important, I would say, awaiting this, the whole episode. Previously, we are using morphine, but now people prefer even the ketamine. I see either of these two, and please remember the dose also. Morphine 0.2 milligram per kg subcutaneously. Another thing, you know, the morphine may not be available immediately. Even in the hospital, if it is there, you will have to take the permission and they will have to get it. Well, ketamine is available, and that is 3 to 5 milligram per kg per dose. It is intramuscular. Third is the correction of the acidosis, because it's the major killer. Soda are 1 to 2 ml per kg, diluted. IVs only. Then propranolol 0.2 milligram per kg IV. If really there is hypovolemia, correct it. Keep the child warm. And here, please see that hemoglobin, if it is less than 12, give the PCV. This is the another very important precipitating condition. Of course, then monitor for all these vitals and vasopressors and mechanical ventilation as well. So these points should come in a very appropriate order. Even similarly, status asthmaticus. Even any patient of convulsions. So they want the exact order that which drug should be there, what is the dose, no response, what you will do. So like this type of one question, they are always keeping in mind that emergency management in a chronology that we should remember. That is the idea. Okay, further. Simple, even the ORS, they may keep the packet in the
245.
245
Yeah.
milliosmol per liter.
And you know what? Why they are keeping these basic questions? Because that developing countries like India, every medical person, not even the pediatrician, should know these aspects. And suppose if you are not able to answer this question, they may not consider you. But this is a very basic question and everybody should know. That osmolarity answer is 245 millimole per liter. Next question, which day is celebrated as ORS day? General question, general knowledge. Even sometimes they are asking for the breastfeeding also.
7th July.
Sorry?
7th of July.
Okay, July is right, but the day is not right. Date is not right.
What is day, sir? 29 July.
29 July.
29 July is the right answer. Right. Even one more question. Bicarbonate in the ORS is replaced by citrate. Why? What are the advantages of citrate?
It increases the shelf life of ORS.
Very good, very good. Yes. Anything else? Very
And
good.
sodium balancer, bicarbonate.
Sodium will be not affected much.
No, sir, acidosis. To prevent acidosis.
One is the taste. Previously we were using the bicarbonate. It was the very bad taste and children were not accepting. But with the citrate, taste has improved. And therefore increased shelf life of ORS, better taste, even unsoiled packets. Previously with the bicarbonate, but in the monsoon season, many packets were wasted. So these are the benefits of citrate. When was ORS introduced by WHO?
2015.
Just general knowledge.
2004.
I think before that, I remember
2001.
But this was there during my residency. And all these problems, what I said, these packets were wasted and everything, where we were facing the problem. Even the taste not accepted by the children. And that was in 79. And who was the person, I have not mentioned over here, but you know who was the person to discover this ORS? Why I'm asking, recently he died.
Dilip, sir. Dr. Dilip.
Yeah, and he was the pediatrician from Kolkata.
Kolkata, sir, yes, sir.
Indian pediatrician. And I think
Dr. Dilip, sir.
Yeah, I forgot his full name, but Dr. Dilip, yes. And I think after his death, even government also awarded some award to him for this purpose. And one more question, even sometimes people may ask, name the condition with this is the low osmolar. The standard WHO ORS was different, but this was appropriate for cholera.
Cholera.
Yes. Cholera. Was appropriate for cholera. So at least what I mean to say on the ORS, any type of question, then the meso ORS, they can say even, they can ask you in a case of malnutrition, this is the low osmolar, this is the standard WHO ORS, all these questions. And the reason is, it is considered as the greatest discovery of this last century. So that is very, very important. Now, some clinical signs. What are the signs to be examined for the capillary refill time? Where you should examine? They will ask in the exam, then demonstrate. How will you do for the capillary refill time?
Sign in the forehead,
Forehead
over
or
the
the
sternum, and the legs.
Sternum or the forehead. These are the common sites where the very firm, bony background, sternum and forehead. For how much time the tissue should be blanched?
5 seconds.
5 seconds.
2 seconds. Less than or equal to 2 seconds.
It is to be pressed for 3 seconds.
Okay.
And what is normal CRT? Less than 2 seconds.
Less than 2
2
seconds.
seconds.
So this is the interpretation, and they are going to ask at least in Viva or even these type of the OSCE stations also, they keep some this type of the short clinical examination. In which type of the shock CRT may be normal even? Patient is in
Warm
shock.
shock.
Warm shock.
Warm shock.
Septic shock.
Septic shock.
Yeah, no, not all septic
Warm
shock,
septic,
only
septic.
warm septic shock. Warm septic shock. So that we should remember. What are the prerequisites for proper interpretation of capillary refill time? If it is not
Appropriate light. Appropriate
Correct
light.
site should be chosen and adequate lighting.
okay,
Ambient temperature.
one is the
Temperature,
gas.
Child should not be hypothermia.
That is very important. Neutral thermal environment, and extremity should be raised above the level of heart. Then and there capillary refill time will be reliable. I think from these investigations, some laboratory microbiology, and therefore this type of question: skin antisepsis during collection of blood for the blood culture. How will you do?
Sir, 3 times we'll have to do.
Three.
First sterilium, then
Okay.
betadine, then one more time sterilium.
Spirit.
Okay.
Now we are using back to prep.
Anything more? Even preparation for the person who is collecting.
Wear sterile gloves after adequate
Yeah.
scrubbing of hands.
After following 6 steps of hand washing, wear sterile gloves. Then,
Gloves.
sir, and one should be assisting the procedure. The one who is performing the procedure should not touch anything else.
I think I have not kept over here, but what they do, I have seen in one of the DNB exam, that they will keep the bottle of the blood culture photograph, and then they will ask all the questions. Please remember, antisepsis, operator must clean and dry the hands, and then use the sterile gloves. 70% isopropyl alcohol or iodine tincture as antiseptic solutions. Then about 3 square centimeters of the skin should be disinfected. Disinfected requires 1 to 2 minutes of contact time for complete action. Allow it to dry. Don't jump immediately for collection. And avoid touching and recontamination. This is very common mistake. It should not be done. And this even in the practical exam also somebody will ask you. How much volume of the blood? That is very important. And particularly different age group in pediatrics.
0.5 to 3 ml. 2 ml. 0.5 to 2 ml.
In newborn, neonatal.
0.5 ml.
1 ml.
We will prefer lesser volume.
Please remember.
Pediatric 1 to 3 ml.
Please remember, neonates 1 ml, 1 to 2. Infants 2 to 3 ml. Common age group children 3 to 5. But the adolescents more, at least minimum 10 ml. And please remember that what should be the proportion of this broth and the blood?
1:10, sir.
1:10.
What do you mean by 1:10?
1 ml in 10 ml.
1 ml
1 ml blood in 10 ml of broth.
broth.
How much the solution is there in your bottle? Commonly what we are getting?
About 10 ml.
The proportion is 1:5.
1.
Why this proportion is defined? What is the idea?
If there is excess of blood and the patient is having sepsis, then the growth of the bacteria will be more. And during uh, checking the sensitivity, there may be post-zone phenomena.
Post-zone and pre-zone phenomenon, sir.
The point is, why this proportion of 1:5 that fixed they have decided? What is the idea?
In that particular dilution, sir, the commensal organism growth is more and the unwanted organisms growth will be less.
Blood here, whatever the organism
Media.
is always responsible for the disease. This is no wanted, unwanted. But why this blood is diluted? Suppose directly if you collect the blood, what is wrong? Why the dilution is required? Very important point. Very important point. Please remember, in the blood, also there are the immunological components which will inhibit the growth of these organisms. But if they are diluted proportionately, then inhibition can be minimized or nullified so that bacteria can grow. And for this reason, this dilution is required. That is very important point which we should know. And similarly, one more point. Suppose if you are not able to send immediately the blood after the collection, where you would preserve?
So blood culture
Room temp incubator preferably, sir. Otherwise,
actually in room at room temperature.
Okay.
Preferably in the incubator, or if not available, it will be in room temperature, sir.
Why the room temperature? Why not in the refrigerator?
The growth of bacteria.
The growth of
must be altered.
contaminated organisms will be more in the refrigerator. The unsterile samples will be kept in that one, sir.
And where you will collect, where you will keep the urine?
So the growth of the organism in the blood culture, which we want to study, will be inhibited if we keep in the refrigerator. But for urine culture, so it's the opposite, because they want the commensals to grow. So that's why we
kept in the refrigerator.
Please remember one principle. Any sterile specimen where you are expecting that no organism, they should be kept at the room temperature and let the organisms grow, like blood, CSF. Here, we don't want to keep them in the refrigerator. But where the contamination is possible, keep them in the refrigerator to inhibit the growth of the contaminated organism. And therefore, the urine should be kept in the refrigerator 8 to 10 degrees centigrade, but not this blood. So this is another point which they are going to ask you. Now, similarly, as I said, one emergency, anaphylaxis. Suppose, how will you manage? So, following some vaccination or following some injection, even ceftriaxone can give the anaphylaxis.
So first we maintain the airway, breathing, circulation, the ABC, and stabilize.
Okay, then, specific treatment.
Specific treatments would be injection epinephrine, which is 1:1000. We give intramuscular.
Okay.
And apart from epinephrine, it is we can give injection pheniramine or injection hydrocortisone.
Okay. Please remember to save the time. The life-saving drug in anaphylaxis is only and only epinephrine. And therefore, even to that extent, suppose if you are giving this penicillin, this penicillin epinephrine should be kept loaded in the syringe. If it does not require, then throw it away. but even keep the epinephrine ready. It is very important. And this is to be given an intramuscular or anterolateral aspect of thigh. Then you can go for IV access. Lay the patient flat and elevate the legs if tolerated. Of course, high level oxygen, airway ventilation, Rajat said, is to be done if required. If hypotensive, first go for the fluids. Again, this adrenaline can be repeated after 5 minutes if required. Oral antihistaminic, some people say yes, but not IV, which we were doing in the past. And steroids have very, very, very questionable role. So don't jump for the steroids. On the contrary, epinephrine will be the life-saving drug. And therefore, mentally, we should be prepared that suppose by chance if it develops, the first give the epinephrine. Then even this go for the IV fluid, hypovolemia. Repeat even adrenaline. I think rest of the drugs are not much useful. Following the vaccination, I think every pediatrician should know. Once a while it happens, but it can happen. And so we should be ready. 1.5-year-old child presented with failure to thrive, muscle weakness, constipation, polyuria, and this is ABG. I hope you are able to see 1.5-year-old child, not gaining weight, failure to thrive, muscle weakness, constipation, polyuria. This is ABG.
Yes, sir.
Metabolic
It is
alkaline.
Metabolic
Metabolic
alkalosis.
alkalosis.
Very good, very good, very good.
Uncompensated.
Absolutely, absolutely. I will appreciate that all of you are right. Uncompensated metabolic alkalosis. And so therefore, one ABG was maybe the commonly they are keeping. ABG interpretation, because that critical patient's interpretation you can do. That is their idea. Then the next question. Mention the 4 clinical conditions in which these type of the ABG findings can be seen. I think this was the question which I have taken from even the DNB exam when I was there. What are the other sides?
Metabolic alkalosis
persistent
is
vomiting.
divided broadly into chloride responsive and non-chloride responsive.
Okay.
The chloride responsive would include persistent episodes of vomiting, diarrhea,
Very good.
persistent Ralph tube aspirations.
Very good.
The chloride, non-chloride responsive, again they are classified whether there is hypertensive, non-hypertensive.
Of course.
In non-hypertensive, we have the Bartter syndrome, the Gitelman's, and the East syndrome, EAST. And in the non-hypertensive variant, we have the Liddle syndrome.
Very good, Rajat. Rajat, you answered absolutely right. In short, gastric losses, then persistent vomiting, nasogastric tube, all the conditions. Even diuretics. Furosemide particularly is known. Gitelman is known, Bartter syndrome is known. These are the common. On further investigation, he was noted to have the hypokalemia. Now, what is your diagnosis?
So most likely
Pylorextenosis.
Gitelman syndrome.
Gitelman.
You know, what is the age of the patient?
1.5.
Yeah, and Gitelman develops at what age? It's a mind
childhood, later.
Many times it is seen in adults even. Gitelman. Very young age, 1.5, so Bartter syndrome. What is the line of the treatment of Bartter? Suppose if you diagnose Bartter.
Indomethacin.
Anything else? Supplementation?
Potassium.
I think here somebody will ask, or as I was telling, suppose oral solution potassium pot chlor is kept over here. What is the concentration of the potassium in this solution?
15 ml is
15 ml 20 MEQ.
15 ml में 20 milli equivalent.
Yeah, 20 milli equivalent per 15 ml.
By 15 ml.
Suppose if you give the patient oral, you are advising what precaution or what you will explain to the mother, how it is to be given.
Mixed with fruit juice.
Mixed with
At least
Needs to
dilute it. Don't give directly. Dilute it in substance. Therefore, you can say half a glass of water or
Half glass
even
of water.
fruit juice. Why this dilution is required? It can cause you the gastric ulceration and even hematemesis. Therefore, potassium supplementation is very, very important. How it is to be given. And what is the potassium concentration? You know, somebody is taking even that IV for IV preparation, that ampule. What is the concentration of potassium in that?
1 ml is equal
The
to
1
2
ml is 2 milliequivalents.
Whatever contains?
2
2
milliequivalents.
2 milliequivalent.
Very good. And therefore, you know, the maintenance IV fluid in 1 pint, how much the potassium chloride should be added?
1 ml per
5
kg
ml.
body weight.
So my
Over
question
24
5 ml.
hours.
My question,
20
yeah.
MEQ.
My
5
question
ml.
is
1:5.
my question is very simple. 1 pint is already you are asking the sister to prepare. You will put the, I would say, order
5 ml, sir.
5
1
ml.
one
Then what will be the concentration of potassium in that case?
20 MEQ per liter.
10%.
10
What?
milliequivalent.
10.
That's what I'm telling you. 10 milliequivalent, how much?
500 ml.
You know, usually what we say
20
milliequivalent per liter.
Then it will be 20
20 milliequivalent.
Therefore, you know, in the
1
maintenance,
ml is equal to 0.4.
in
So
maintenance,
we added 2 milliequivalents per kg per day in a 24-hour IV fluid.
roughly, if I say the maintenance IV fluid, suppose if you have taken the DNS, then add the 5 ml of potassium chloride so that it becomes a 20 milliequivalent per liter. And that should be the concentration of potassium in maintenance IV fluid routinely. Some specific condition is a different situation. Therefore, this is a very common question which the people will ask. But suppose in a case of Bartter syndrome, presented with very severe hypokalemia, then what you will give, how much you will potassium you add?
40
milliequivalent per
40 MEQ per liter.
So if it's a peripheral line, then 40, central line, then we can go up to 80.
Please remember the point. Very good point, Rajat. But, you know, the Bartter syndrome, we can go for commonly 40 milliequivalent per liter. Very severe, suppose hypokalemia is life-threatening, you can increase to 60 milliequivalent per liter, but if 60 commonly give by the central line, not the peripheral. And 80 probably I will not give, may give by nephrology. But 60 I think for general pediatrician, okay. Have you heard what is the pseudo-Bartter syndrome? Looks like Bartter, but it's not. Pseudo-Bartter.
Pseudo-Bartter.
It looks like Bartter, ABG and everything, but it's not Bartter.
Furosemide.
Use of furosemide.
Yes, sir.
Furosemide.
Any disease?
Cystic fibrosis, sir.
Very good, very good. Cystic fibrosis will present as a Bartter-like picture. But where is the chloride is lost? You know, chloride is lost. Chloride is lost in a case of Bartter in the renal. While chloride is lost in the sweat in a case of cystic fibrosis. And therefore, if you see the clinic picture, it's just like this Bartter. Failure to thrive, everything almost. But later on, if you see, and one of the patients I remember, which I treated as initially, even this as Bartter, turned out to be the cystic fibrosis. So pseudo Bartter. And these are the questions I'm sure that if you know, people will ask more and more questions. Now, one more, another variety of the question, which is commonly nowadays people are putting in. A female child 18 months has been diagnosed as a case of simple febrile seizures. Now counsel the mother on the disease and its management. Who will take one person?
Sir, Sayan.
Okay, do it.
Sir, first of all, I will introduce myself, make a positive rapport with the parents.
Right.
And we'll introduce, means we tell about the condition, briefly about the condition, means what the exact sign symptom that develop. And we reassure the parent that it may happen. It's about the duration, 6 months to 5 years, it can happen and nothing to worry. And about the simple febrile convulsion prophylaxis, about the warning signs of the disease, and about the about the prophylaxis for with PCM and about the warning signs, and if it sustains, then we quickly revert back to the nearby hospital.
Very good.
I will also counsel the position when if seizures occur at home, and also counsel there will be no cognitive delay in the case of simple febrile seizure. So they should not be worried about the brain development in the future.
Right, very good, very good. I think these points very nicely both of you have done. Absolutely. That always, for the counseling, this is now going to be the very common question. Almost in every exam, whether it is the DNB, whether it is the MD examination, even suppose if you diagnose cerebral palsy in the long case, then at the end they will say that how will you counsel? Suppose nephrotic syndrome, febrile seizure, even epilepsy. In all these conditions, suppose Down syndrome. So you should know the common condition that how you should do the counseling. First, always, directly don't jump for the condition. Say that I will talk to the parents, introduce ourselves to whom you are talking. You can say that I was fortunate to get the opportunity to treat your child. Something, this type of the phrases should be used. Then you can say that based on already what I ask you and examine the patient, I diagnosed that it is having the simple febrile seizures. What we say, you can say that this is common in 6 months to 5 years. Very rightly he did it. Then you can say that, but the recurrence is possible in significant number of children. And then suppose by chance it happens, then you can say that even the earliest for the recurrence of the fever, even the clobazam, commonly used prophylaxis for the first 3 days of the fever. Fever should be treated promptly, as you said, that paracetamol should be the drug of choice, no other drugs. By chance, if at home or somewhere, suppose develop, then what they should do, explain this is very important. Position of the child to prevent the aspiration. Midazolam nasal spray is very important. Even paracetamol suppository, because orally they cannot give. So suppository, and now it is available. Don't put anything for prevent the injury. That is very important. And reassure that prognosis is good. They are more concerned with the neurodevelopment. So you can say that usually there is no problem. And even at the end, always in the counseling, keep this open question. That if you have any query, you can ask me. Even you can give me this my contact number, you can call me. This is, I will say, the good generosity on the side of the medical person in the counseling. So at least this is one example which I have taken, selected. But in other conditions, any condition they are going to ask you. So counseling, you should prepare that if they ask you that how we should do. I think similarly, one question very important, even in the some newborn comes.
Factor 2, factor 7, factor 9,
Factor
factor
2,
10.
7, 9, 10.
2, 7, 9, 10.
Very good. Even protein C and protein S also.
Protein S, yes.
Then what test to diagnose deficiency of vitamin K?
So protein inducing vitamin K absence, PUCA level.
Very simple, commonly what we are doing, PT and APT. Right. And the third question, define early classical and late hemorrhagic disease of newborn.
Early hemorrhagic disease of newborn occurs within 24 hours, while classical occur within 7 days, 3 to 7 days, and late occur after a month.
Yeah.
This
is very important, and early within 24 hours, and this is mostly related to some anticoagulant drug taken by the mother. Most of the times the etiology in the early and classical up to 7 days of life. That is because the breast milk is a very poor source, and if you are not given the vitamin K prophylaxis, it can develop. Late after is only 2 weeks, which can even up to 3-4 months. And prophylaxis is very important in newborn, and that intramuscular vitamin K 0.5 milligram in less than 1.5 kg weighing the weight, and 1 milligram in the baby where the birth weight is more than 1.5 kg, and single dose vitamin K. How commonly classical hemorrhage of newborn patient presents, what is the most common presentation? What I mean to say, bleeding
IC
side,
bleed.
bleeding
IC
side,
bleed.
classical hematomesis,
Bleeding from
GI
GI
bleed.
bleeding.
vaccine
GI
site from
hematomesis.
hematoma.
On the contrary,
Hematomesis.
late is common with this intracranial hemorrhage. So manifestation is very, very important to keep in mind. So this is a very common question they are going to ask, because this is very important. No pediatrician should miss the vitamin K in the newborn. That is a very important message. Anyway, now this type of the again counseling, that it is diagnosed as celiac disease. Now, how will you talk to the mother regarding dietary management of the child? Who will take it? And you know, nowadays celiac is not uncommon. Therefore, they are focusing. One person should take it, no problem. Whatever you know, you can discuss. One
Sir, I
person.
want.
Yes, sir, please.
Science, sir. Sir,
Yes.
I will first introduce myself,
Right.
make a repo with the parents, and I will counseling about the disease, how it develops, and what the dietary modification that has to be needed. Like, sir, FODMAP diets, then barley, rye, oats, and wheats should be should be avoided, and gluteins can cause this disease. They might have some skin symptoms, about the risk factors and hazards, and in any case, in case of any acute exacerbation, they have to report to the nearby center, sir. And about the, I will provide my numbers and all for emergency contact.
Right. Anybody wants to add something?
Then we have to evaluate for vitamin D deficiency
Very
and
good.
associated bone, skins, and joints, sir.
Right.
And some associated disease, sir, that screening and all can be needed, like Downs, then atlantoaxial instability of the joints,
Okay.
then
We have
that can be, sir, can be related to yearly screening of that for those diseases can also be done, sir, for subsequent
that
follow-up.
investigate for other autoimmune disorder like type
Yeah.
1 DM,
Yes, yes. That's
thyroid.
good. But you know, I think that is not for the mother. That is for us to keep in mind.
Yes, sir.
Of course, I think basic all of you know, but how you have come to the conclusion, always say like this, that I ask you the details regarding the illness. I examine the patient in details. You know that already we have gone for some investigations, even including the biopsy, because you know, without biopsy, you cannot label it as celiac disease. And now you can say that it is diagnosed as celiac disease to your son. What is it? You can say that this is the condition which the child is unable to tolerate or digest the wheat and wheat products. That you come to the focus. Then what we can do? Explain the treatment of this condition is to exclude that very important, that wheat should not be in any of the diet. And that is very important, that even oats and barley. And keep in mind, tell very frankly, clearly, that this is for lifetime. You know, they are going to ask you कि after for some time, वो बड़ा हो जाते दे सकते हैं बाद में. So all the points we'll have to explain from the beginning. And give some examples of wheat containing preparations, commonly which you are using, that atta, therefore chapati, bhakri, parotha, but some maide, therefore suji, chapati, roti, bread even, biscuits,
Pizza.
commonly we are using pizza, halwa, particularly sira, you know, glapsi, Gujarati family, they are using laddu, upma. If you are not sure regarding the item, this is very important, tell them. When sometimes parents are asking, I say, I will have to check it. I'm not sure whether it contains wheat or not. And if you are doubt, then don't give it. Even, you know, I came to know later on that the ice cream contains the wheat. So these are the things that if you are not sure, don't give it. This is the point which we should emphasize. Then what they can give, that you can explain.
Rice.
That all the rice preparations, maize, bajra, jowar, all the things they can take. And even tell them that these because child should not feel that not getting. Therefore, best way is to change the menu of your family diet. That is very important. Then you can say that once we start and you adhere to this wheat free, then at least some improvement will be seen after 3 to 6 months in the form of the weight and height gaining. And even we can repeat the serological test after 3 months. And many times, suppose some child is celiac, gluten-free diet, and if you go for the serological test, may come negative. It does not exclude this. I have seen even some of the patients. So that is very important. And ask the parent regarding their doubts, any queries, even this is very, very important. So the points I think you should know regarding this, that how you come to the conclusion, then what type of the specific some treatment part and even the diet, and therefore how much time, and then what is the follow-up. Even sometimes, suppose in a case of tuberculosis, follow-up is also very important. So all the points in short in the counseling should come. I think we'll take few points, then probably we will. This is the X-ray. Incidentally, X-ray showed this picture in 2-year-old child, which was asymptomatic. For some upper respiratory, somebody has taken for fever cough, and this is the X-ray.
CCAM, sir.
Sorry?
Hydrated cyst.
Hydrated cyst, sir.
Hydrated cyst.
CCAM.
Which side hydrated cyst?
Left side.
Where is the heart?
Dextrocardia, sir.
Next.
Dextrocardia due to what? And where is the left dome of diaphragm?
Evaluation of that.
Sorry?
Diaphragmatic
No, sir.
version.
What version? Diaphragmatic?
Eventation of diaphragm.
Eventration.
Yeah, that
For
is very
ventilation.
important. Very important. This is congenital eventation of left dome of diaphragm. It is eventation, it is elevated. That what rounded is seen is the, I will say, gas in the stomach. But the whole, you are able to, I hope that you are able to see this is the dome of the diaphragm, whole left dome of the diaphragm. And therefore, due to this heart is pushed on the opposite side. The question comes, what are the other differential diagnoses? Some of the already you have spoken. Even diaphragmatic paralysis. Now you don't get, we used to get in poliomyelitis, hereditary paralysis, C3, C4. Or even the iatrogenic injury to the phrenic after even the cardiac surgery. I have seen 2-3 patients. They got the injury and then there's a problem. Of course, diaphragmatic hernia, you can keep it, but then you can exclude. What other conditions may be associated with congenital type? That is the point. Pulmonary sequestration, congenital heart disease, some chromosomal trisomies. That is 21, 18, 13. Okay. Now another list of the question. 18-month-old child present with severe pallor. What are the history points? Very important points with the reference to anemia. We will collect from the mother. History points. Who will take it? This is exactly the question which I have taken from the DNB exam probably a few years back.
Sir, again, I'm just highlighting the points. We'll just introduce myself, give a report. I will just ask about the maternal history, maternal drug intake, any bleeding during the last year, during or just during or just after the delivery. Then, sir, about the dietary habit of the child.
I think an 18-month-old child, how that maternal history will be related? Do you think that factor develop the anemia in 18-month-old child?
Sir, about the strict vegetarian vitamin B12.
Okay, so dietary history, good point.
Then any repetitive blood transfusion history.
Very good. That will be the idea. Whether
Drug
it is
intake.
really hemolytic anemia or so. Then?
Any family history, drug intake.
Okay.
Sir, when was complementary feeding introduced to the child, sir?
That is very good, absolutely. Because the milk diet, prominent, that is responsible for anemia. So dietary detail go that how much the child is consuming milk, and 18 months may be the age for that. Very good point. Then, anyway, to save the time, I go. That onset of pallor is very important, sudden or gradual. Sudden can be in a case of G6PD deficiency, hemolytic anemia, even malaria, right? Gradual may be the nutritional. Then dietary history details, all the points what you asked, whether it is purely vegetarian, non-vegetarian, what is the consumption of milk, complement is started properly or not. Then suggesting even worms infestation, very important, right? Even the history of bleeding per rectum, or even the bluish spots, or any drug, very important, particularly aspirin in a case of Kawasaki. Associated symptom, fever, weight loss, maybe in a case of even the malignancy leukemia. Jaundice may be the indicating hemolytic anemia, transfusion, same hemolytic. Similar problem in the family, spirocytosis. So then community is very important. Consanguinity is very important. Autosomal recessive thalassemia. Even geographical history is very important. Family background. So all the points in short, keeping in mind that what are the etiological factors you want to know, and that points in the history should be collected. What is the characteristic clinical site present neonatal period?
Bilateral pedal edema.
Yes, Turner, non-pitting edema.
Non-pitting edema.
Two characteristic cardiac anomalies in Turner.
Bicuspid aortic valve.
Most common, fast. Most common first.
Coarctation of aorta.
Very good. Most common is coarctation.
Coarctation of aorta.
Then bicuspid one or aortic stenosis, you can say. You are right. Two common endocrinal problems, Turner.
Hypothyroidism.
Okay. Even the diabetes and
Type 2
autoimmune
diabetes.
thyroid. Which GI disorders are known to occur in Turner?
Celiac disease.
Celiac.
Very good. And most common renal malformation is
Horseshoe shifting.
Yeah. And Turner syndrome again can be the common gist of the one syndromic condition. X-ray chest of the newborn taken for the respiratory distress. What you are able to see?
Congenital
diaphragmatic hernia.
Very good on the left side. Congenital diaphragmatic hernia. That is the Bogdalex type.
Posterior type.
Yeah. Posterolateral. Say it is the posterolateral. Yeah. What problem is faced when the clinician is resuscitating such a baby with bag and mask?
Do you agree with the problem, sir?
Yeah. On the contrary, baby suppose asphyxiated, if you go for bag and mask, baby should improve. But here, baby will deteriorate. What is the line of the treatment?
Surgical option.
Very important question. What associated condition is limiting factor for survival of the baby?
Pulmonary
hypoplasia.
Absolutely. So C is for the pulmonary hypoplasia. One more X-ray. Child was brought with complaints of cough, chest pain, and dyspnea. This X-ray was taken. You can focus.
Boot shape.
Pericardial effusion.
Pericardial effusion.
Very good. Who said pericardial effusion? Please give your name. Yeah, and I think one female voice was also there.
Subhashri, sir.
So say it loudly, right?
Subhashri.
Yeah. So here it is the
bottleneck appearance.
Diagnosis very good, pericardial effusion. Most sensitive diagnostic modality is echo. Anyway, just I'm going little bit hurried to show you some of the X-ray. 10 months old child develops severe intermittent pain and mass on right side of abdomen following diarrhea.
Malnutrition of the gut with meat.
What is this investigation?
Barium anemia.
Yeah, barium anemia. And it is intussusception. Please never miss the rectal examination. That's the point. I think one or two, three, 4 slides will complete so that one session will be completed. Pedigree is very important now. They are going to ask you the pedigree, and pedigree I have seen in many DNB exam, the OSCE stations. Look at this pedigree. and identify the pattern of inheritance.
X-linked recessive, sir.
Very good,
Yes,
very
yeah.
good. You can see all the females are carriers and
Male.
male sufferers. So it becomes the X-linked recessive. Name other conditions with similar inheritance. Some other conditions, X-linked recessive.
Hemophilia A,
Hemophilia.
Yes, very good.
color blindness,
Yes, very good.
G6PD deficiency,
G6PD.
I'm keeping for your
DMD.
information. I think all of you know. Very good. Rare is Menke-Kinkin head disease.
okay.
What is the risk of getting affected in each pregnancy? What is the risk of getting affected?
25%.
50.
Very good. 50% for male child.
Male child.
Please remember, 50% for the male child. So this type of the pedigree, these type of questions they may ask you. This is my idea to sensitize you. So prepare the pedigree. Very few common conditions they will keep it, not the uncommon. What type of inheritance in this pedigree? You can just look at.
X-linked recessive. Autosomal recessive.
Recessive.
Yeah,
Autosomal
absolutely.
recessive.
If you see they are taking this gene with this consanguinity suffer. That is the thalassemia, what happens in autosomal, right? So this is autosomal
Autosomal
recessive.
recessive.
And what is the risk of recurrence in next pregnancy? That is the common question.
25%.
25% with each pregnancy.
Each.
Of the following, which is consistent with this type of inheritance, which one? Which one is having the autosomal recessive?
Niemann-Pick disease.
Very good.
Niemann-Pick.
Very good. Very good. Very good. 10 months old male child has been brought with a large tongue. Somehow it is cut, probably I could not manage. Birth weight was 4.2 and no perinatal complication. What is the most probable diagnosis? Yes, I think tongue in this picture is seen.
Back with
Wittmann syndrome.
Very good.
Back
This is back
With
with Wittmann
Wittmann
syndrome.
syndrome.
But my question is different. What are the features of this condition that you can see?
macrosomia.
Macrosomia.
Common features of
Microcephaly.
Ophthalmoscopy is seen. Macroglosia, microcephaly, very good. Visceromegaly and hemihypertrophy. And which chromosome carry the gene responsible for this disorder?
Chromosome
15.
11. And what complications are known to occur in this disease? Complications.
Wilms tumor.
Very good, very good. What are others? Wilms tumor, hepatoblastoma, chorioblastoma, adenocarcinoma, rhabdomyosarcoma. All these are the very dangerous conditions. I think should we end over here?
PCG1890, sir.
Yeah. Why I'm keeping it that already we have crossed 8. I'm sure that we request Nehal before our examination, we may keep one more session so that because probably we have reached to the halfway or so, less than halfway. I think you can give me your feedback on, now I'm there in the multiple groups because I've always remained with the students. So you can give me the feedback regarding your interpretation. Even suppose if you want in some, what I have kept in that, I know these particular OSCE stations since many years. And what even they are changing the different methods, that also I'm keeping the watch. And keeping that points in mind, I have prepared this type of the questions for you. And many more such questions are there, I'm sure, and it can be useful at many places, not only the OSCE, even in the short case or Viva table at multiple places. I'd be happy that probably many exam prepared students were responding very nicely. I came to know some of the names also, responding very appropriately. It shows they are obviously good preparation. And please, whatever the skill you have 1 month, you can utilize in a better way. Anything for me, even you can ask me at any time. I will try to answer you. Probably will request Nihal that if possible next Saturday or after that, We'll keep one more session. So probably most of the things will sensitize you, will give the idea that what type of the common OSCE questions are there. So should we end over here? Is there, I will say Nihal is there, or she may be busy with Pedicon. Anyway, I think already we have crossed 50 minutes 8. So we'll end over here. Again, as I said, that next session we'll keep. And meanwhile, any question you can ask me. I take the opportunity to wish all of you the very good performance in your practical examination. I think before that, again, we'll meet. But in the advance, I am conveying my best wishes. Thank you very much.
Thank you, sir.
Okay.